Thanks, Harvey. And as I indicated, I'll also introduce my colleague Jenny Francis, who's been closely involved because of the legal nature of this work. We received about 35 questions ahead of time, there's a few common themes in those. And so I think that I'll cover off on those common themes, and then my colleague Dr. Talvi Fenner has been receiving all the questions that have been coming in during the webinar. I know we're down to go to 6, and we're very happy to be here till then, but we'll see how we go. We may cover off most things in 30 or 40 minutes, but that's really up to you, the audience. So one of the questions that's been asked is, well, why prescription only? I mean, there's other nicotine-containing products for smoking cessation that are pharmacy only, pharmacist only. There are even some that you can buy in supermarkets. And this goes back to what my colleague Avi Rivera says. When the committee looked at the appropriate scheduling, and in every time they make a recommendation to the delegate, they actually have to decide, should it be pharmacist, should it be pharmacy, should it be supermarket, should it be prohibited, should it be under lock and key, should it be prescription, or so forth. They looked at such things as the amount of nicotine, and while a patch may contain the same total chemical amount of nicotine, because it's absorbed through the skin slowly, it affects the body in a very different way from a large amount of nicotine hitting the lungs. They also looked at the risk of use other than for medical purposes and other than for smoking cessation purposes. And while we've seen data on a doubling or tripling in some cases of teen vaping, there's no similar trend for teenagers to go to Coles and Woolies and binge on nicotine patches. So the large concentrations. The other thing that also the committee considered at the time was the way it enters the body. So nicotine in a vape obviously enters the lungs and goes to the brain very quickly, and a large proportion of the inhaled nicotine enters the lungs. Whereas, again, with a patch or even a spray, a smaller proportion more slowly enters the body. So those were the factors when those scheduling criteria were looked at under the law in this 52E, Section 52E of our Act. And if you've got insomnia, go and look it up. It's on our website. They were the criteria that led the committee to recommend that it be prescription only. And also, for the purposes of smoking cessation, it was felt that given that smoking is one of the biggest issues in individual health, you know, when a GP sees their patient, that it's important to integrate it into the smoking cessation discussion. So they were the factors why not pharmacist and not supermarket. So the other question that's come through is, well, hold on, you guys are being inconsistent. You're not trying to do anything with smoking cigarettes, and we know that combustible, you know, smoking cigarettes are more harmful than e-cigarettes and or vaping, and we would certainly agree that the evidence does suggest that, especially because of tars and other things in smoked cigarettes, they are more harmful. Although the evidence also is unequivocal that vaping is not harmless, and nicotine vaping can be quite harmful. So why isn't TGA trying to propose a similar change for tobacco smoking? Well, again, as a regulator, we work within the law of the land, and the scheme for regulation of scheduling was set up some 50 or 60 years ago. And back then, certain types of products were carved out. So it says that TGA has no control over tobacco smoking, and there were other things just for interest. Printers' inks and photographic chemicals were also carved out back in those days, because it was felt that there were either occupational health and safety laws, or there were also state and territory controls over cigarette smoking. And this was at the time where prohibitions on advertising, prohibitions on advertising during children's shows, prohibitions eventually on any advertising, prohibitions on smoking inside and so forth. These are all things, and the control of sale is all under state and territory legislation. So because of a state and territory bit and because of the historical carve-out, tobacco smoking is not in scope. So it's not a matter of considering this versus that. It's just that when it's in the form of tobacco being burnt, it is specifically excluded by law from TGA's regulation. Another series of questions that we've had is will the changes enable consumers who are wanting to quit smoking have access to a range of flavours and nicotine levels? Well, there's no proposal in the interim decision to limit flavours and nicotine levels. It may be that some submissions come in and propose to the delegate that for children, because of a risk of attraction to children and teenagers, candy flavours should perhaps be excluded. There's nothing like that at the moment in the proposal, and certainly recognising the fact that different heavinesses of smokers may require different strengths of vape liquid, it would be important to keep a wide range of products available. And we believe that the market will operate. There are companies who will be interested in importing these nicotine solutions legally into Australia, and there will also be pharmaceutical wholesalers who will also import these products legally into Australia with the right pharmaceutical wholesale licence. So so they're the main issues. And of course, the other question we've had is, well, why couldn't this become a TGA? Why couldn't nicotine for vaping or particular vaping products become TGA-approved medicines? And we'd certainly be happy to look at them in the same way that, say, Nicorette inhalers have been looked at by TGA. Now, with those products, you've got to look at the rate and entry and speed of absorption of the nicotine, and also where it ends up and what else is in those fluids. And so we have always said, and we reiterate, that we would welcome and would be happy to have initial no obligation discussions with any company that would be able to submit information on safety, quality of a product, and efficacy. Now, at the moment, the difference is that there are a range of quality of evidence about vaping. So, for example, the evidence for things like a Nicorette inhaler or a patch or a gum is actually stronger in the clinical literature for smoking cessation, and that's why they're TGA-approved products. But again, we'd welcome an approach from a supplier or manufacturer, and we'd be happy to have the discussion about the data that will be needed. If it were an approved product by TGA, the availability we anticipate would be even wider. At the moment, the availability under prescription is relatively narrow because when people are able to purchase over the internet for any purpose, not just smoking cessation, there's little motivation to go to your GP to have that discussion. Some of the other questions that we were asked, just before I turn to the other one, is, well, who can issue a prescription? As I say, anyone who fills in the online form who's a doctor registered in Australia can become an authorised prescriber to issue a prescription. Another question we've been asked is, will vaping devices be regulated? And this person expressed concerns with the safety, and certainly in the early days, and even now from time to time, there are issues with batteries and things exploding within vaping devices and so on. We have no intention to regulate vaping devices because our advice is they're not medical devices, so they fall outside the scope of our regulatory scheme. Plus, we believe that if there are issues with safety or performance in an unsafe way, these are already covered by Australian consumer law under the ACCC. So I think they were the main sorts of issues. There have been some questions saying, well, what are you doing to work with the pharmacies? Remember, the pharmacists are part of it, but the major thrust is that for the purposes of smoking cessation, individuals will be able to have a conversation with their doctors, and that any doctor in the country will be able to apply in a process that probably their receptionist will do with their sign-off, which will take a matter of seconds on the internet using a form that's downloadable. Many Australian doctors already apply for unapproved medicines. So there's over 100,000 prescriptions written in Australia for unapproved medicines. So this is a mainstream activity. As I say, at the moment, very, very few are written for nicotine, because at the moment there is, if I'm buying nicotine directly from an overseas source, people don't see a need to go to their doctor. But then they're missing the opportunity to have a smoking cessation discussion. So we're working closely with doctors' groups, general practitioners, but also other groups, other chest doctors and so forth. We're working with the pharmacists and their supply chains. And it's in anticipation of a possible decision being made, but noting that there would be an implementation period. Even if a decision were made in December, there'd be an implementation period of several months. But I'll now open it up and ask our colleague to ask any of the panel. I'll ask my colleague, Dr. Tali Fenner, who's been receiving the questions, to address them to the panel.
Okay. A lot of the questions that are coming in actually follow a lot of the themes you've already covered, John. So I'm going to I will try and focus on the ones that are touching on something that you haven't already covered.
With my colleagues.
What you did talk about the quick mix products, the sprays. There's been some concerns beyond that raised about children having access to that liquid nicotine and the inconsistencies, and also the inhalator products. And I just wondered if you wanted to expand perhaps on that.
Yeah, so with those products, whether they're available in a pharmacy or in a supermarket for smoking cessation, and some are and some aren't, have all been thoroughly examined by TGA. We have information on the maximum amounts of nicotine that enter the body. They are also, in general, they don't provide as much of a nicotine hit into the bloodstream. And one of the things that's done when a product is submitted to TGA is data on how much goes into the blood and how quickly is provided. So a number of the vaping products, especially at the higher ends, but even at the middle ends, and especially the nicotine salts, provide much faster and much higher peaks of nicotine. And for that reason, this independent committee who looked at the data said, at the moment we think that these are more appropriate for prescription only, even though the ones that provide a smaller amount of nicotine coming in more slowly are available through pharmacies or even in supermarkets. On the other hand, there are some people who suspect that the bigger hit of nicotine from an e-cigarette, because it mimics smoking more closely, will be more effective once the data is assembled in helping with smoking cessation. Some people say one of the challenges with putting a patch on or a lozenge is it's a little bit like trying to give up vodka by drinking light beer. It doesn't work very well because the amount and rate that the nicotine enters the body is so much slower and so much less that it doesn't really mimic smoking, especially if you're a heavy smoker. Another question that we're often asked about is, well, will doctors be limited in their periods of prescription? And any prescription in Australia has a maximum period of a year, and that's been it for any medicine, and that's intended so that there's regular follow-up. Now, in practice, many doctors will say, I want to see you after 3 months, or I want to see you after 6 months, depending on what the situation is and what the individual's general health is. If you had someone giving up smoking who's developing bad chronic obstructive pulmonary disease, COPD, or asthma, the doctor may want to see them much more frequently. And so we're not going to mandate, other than the national limit of a year, we're not going to mandate any period or number of repeats or anything like that with the prescriptions. That will be up to the doctors to decide.
So it might even be worth also just touching on that suppose products, if there are concerns about children accessing them, actually come in child-resistant packaging as well, because they're products registered on the AA.
Yeah, so those others are in child-resistant packaging. And one of the things that we're hoping by this consultation is to get feedback on whether it's appropriate for vaping liquids to be child-resistant packaging. And again, many are already, by responsible companies, are already being provided in child-resistant packaging. That's one of the questions the delegate has asked in the public consultation. The other thing is, by medicalising it, people, even if a medicine's not in a child-resistant package, tend to store their medicines in a cupboard, whether it's above the stove or wherever that a toddler can't reach. People tend to, by habit, put medicines in a place that little kids can't get at.
I think the other thing too is that the other concern is that while some of the existing smoking cessation products are available more widely, with the e-cigarette products, just the fact and the number of flavours that are available do make them more attractive to younger kids as well, which at the moment is another big difference between the current products that are available.
Some of the other ones tend to come just in a tobacco or a menthol or whatever flavour. Yeah. There's not too many Nicorettes that are in bubblegum or watermelon flavour.
So following on from that, you mentioned medicalisation, and that's really good lead into. There's quite a few questions here around why we're looking at smoking cessation and not harm reduction, and where does harm reduction fit into this?
Well, the harm reduction, that's a very good question. The harm reduction discussion is really one between the prescriber and the patient. So I think that most of the prescribers, and prescribers will differ. We all know doctors, like the rest of society, are on a spectrum. And so I would argue, though, that most doctors, GPs or specialists or public health professionals would still see that getting off nicotine altogether, whether it's in a matter of cold turkey, a matter of weeks, or even if it takes a couple of years, is still desirable. I mean, nicotine, even though nicotine e-cigarettes or nicotine vaping, call it what you want, is certainly less harmful than tobacco smoking, it is certainly also not harmless. There's many, many studies in the clinical literature to show that nicotine, and often associated with other things in the heated liquid in vaping, is certainly not harmless, and that the ideal public health and individual health outcome is to get off nicotine altogether. We realise that people will vary in how much they'll be able to transition off nicotine, and that really is a discussion about between the individual doctor and the individual patient. There will be some doctors who say, well, okay, I realise you can't give this up in a matter of a couple of months or whatever, let's work on a harm reduction campaign, but I would still argue the endpoint will be smoking and nicotine cessation, but the doctor and the individual will have a discussion about the period for that to happen.
Okay, that leads quite well into, we've also got quite a few questions around finding the doctor who will prescribe. So, asking, what will I do if my local doctor doesn't prescribe? Questions about how that links to telehealth and getting telehealth rebates when they go to a doctor that's not their own. And also, how are we working with GPs? What are we doing?
Again, given, and of course, this work hasn't started in earnest. We've had a number of chats with the College of GPs and the Australian Medical Association, as well as with GP education groups. But of course, we wouldn't start this work until we know whether or not this is going to go ahead or not. And so we're in this funny situation. But given that there would be a period of some months before this would be implemented, there is an investment that we will make in education of GPs on, firstly, what you have to do, which is very little to become, if you so wish. The paperwork is almost nothing. It's an online thing where you put your number in. They do that already to subscribe to online e-zines and so forth. So, and it would be a bit about the evidence for and against vaping and smoking cessation, and also about strengths and so forth. So an education package is planned if the decision goes ahead, and will be implemented immediately a decision goes ahead, and be an active process with GPs across the country and other medical practitioners and pharmacists in the months leading up to the system implementing. Now, it may be like, and I'll show my age, and I'll go back to the 1970s when some GPs on moral grounds would not prescribe a contraceptive pill. I mean, it sounds amazing to say that in 2020, but in the 1970s there were quite a number. There, you obviously can do one of many things. You can go to a different GP. You can do that in face or telehealth. Now, some may charge when it's not your standard GP by telehealth. Or alternatively, there will also be a number of smoking cessation clinics, there are already some in Australia, and we expect that they will grow, who will have GPs and other physicians who will, by telehealth, provide advice and, if it's appropriate, to have a discussion about providing a prescription. And so, even if your local GP, a bit like the Catholic GP perhaps of 50 years ago, does not prescribe the pill, or if your local GP for some reason doesn't prescribe nicotine. But I think that there would not be a GP in the country who would not be interested in encouraging patients to smoking cessation and wanting to have that discussion with their patients who are smokers. It's one of the apart from losing weight and drinking less alcohol, giving up smoking is one of the top public health priorities of almost every GP in this country. And so I can't tell you whether it's going to be 100%, 90%, 80%. It will grow. It'll start slow and it'll grow. But we've got this lead, assuming this all goes ahead, we've got a lead time of several months. And of course, we realise there's people in rural and remote areas. And so for that reason, and you already have a challenge if you're a couple 100K from a GP. So for that reason, the government has brought in telehealth, plus there will be an increasing number of smoking cessation clinics that will offer telehealth consultations for the purposes of if a vaping is appropriate, of providing a vaping script for giving up smoking.
Just to drill down into that a little bit more, so I've got a specific question about, can a doctor who's not an authorised prescriber write a prescription for a patient who wants to import through the personal importation scheme?
Yes, so they can. There's another thing known as a special access scheme, which is for individual patients. Now, that doesn't require any prior approval from TGA other than filling in the form and it doesn't require their approval for them as an overall authorised prescriber. But again, it's a simple form, but it's around an individual patient. But we will encourage as many GPs as possible to become authorised prescribers because it lowers their paperwork and red tape and it lowers ours and it makes it easier for the patient. But they can do it under the special access scheme. And as I said, the special access scheme, it sounds a bit arcane, but about 110,000 prescriptions were written under it last year in Australia alone. 110,000.
Now, following on from that, we've got a few questions just around comparing what's being proposed here and the approach that the delegate's looking at compared with what's happening internationally.
Well, I guess the view, and I know public health professionals have a range of views, but the view of, I'd say, the majority, and certainly of the Department of Health, and certainly of state and territory departments of health across Australia, and as I say, that of many public health physicians, is that this is something we're actually happy to be out of step with the rest of the world. So when you see the sheer numbers of increase in, the fact that you've got 27, 28% of high school kids introducing themselves to nicotine in 2018-19, that's seen as a very backward step in the health of those kids and the health of those young adults. And so this is one area where Australia, a bit like opioids, doesn't want to follow the American, or COVID for that matter, frankly, doesn't want to follow the American or the Canadian model or the model in many European countries. So we believe that if managed well, it can reduce the on-ramp for young adults and children to nicotine while still providing a means for adults who want to vape and reduce their cigarette consumption and hopefully eliminate their cigarette consumption to get off. We don't want a generation of children and young adults with a nicotine addiction. Nicotine is highly addictive, as many on this webinar will know.
We've got a specific question here or comment, but I think it's something that you might want to expand on or talk to. Under the customs prohibited import regulations, personal imports of nicotine are proposed to be banned from 1st of January with a penalty of $22,000 for offenders. If this happens, will the personal importation schemes be unavailable?
Well, if it did, it would be, but we don't know frankly, we do not know whether that will go ahead. I'll ask my colleague Jenny Francis to explain. They're quite different in law. That one that various ministers have discussed is really in the lap of ministers. Whereas, as we explained at the beginning of this presentation, the scheduling decision, which allows personal importation, is a matter of a senior medical officer, a delegate.
That's right, John. So under the customs prohibited imports regulations, if they were to be made, an individual is not eligible for a permit to import the particular medicine, the e-cigarettes containing nicotine. But as you say, under this scheme, provided that is the scheduling, provided that the individual has a prescription from a medical doctor, then they can, as you pointed out, import up to 3 months supply at one time and a 15-month supply in a 12-month period.
And so, as I said, we don't have information on whether the planned January date for that will go ahead or whether indeed the customs regulation changes will go ahead. That's a decision by ministers with the approval of the Governor-General. It's a quite separate process that's much more tied up with Parliament House as opposed to a decision by a medical professional, which is what scheduling is.
Okay. We've got a couple of questions around who we are consulting with, or who the TGA delegate's consulting with as part of this process. Particularly, some people have asked about the Medical Board of Australia or AFRA, but perhaps worth talking more broadly about that consultation process. I know you've already covered a little bit.
I'm happy to reiterate that. So, as I mentioned, there are 2 opportunities for public consultation. Generally, the peak bodies and the medical associations provide their submissions to us during those periods as well. Very often, too, myself or the team might actually get separate emails, and then we would provide those to the delegate and to the committees as well. We haven't specifically gone out and approached any particular individual organisations.
I actually have
Okay.
I've had discussions with about 10 major medical organisations and pharmaceutical organisations, such as the Australian Medical Association, at the president or chief executive officer level, the Royal Australian College of General Practitioners, and so forth. So that's in addition to those submissions.
Okay, good. So we have gone out then. Thanks, John. But certainly, a lot of these organisations do provide their own written submissions as well, in which they tend to address the 52E criteria and give us that evidence in terms of their submissions as well. Yeah.
Excellent. Jenny, we were talking about the personal importation scheme, and there's been a few questions come up as well around that. Is it worth clarifying? Did you want to clarify?
Just that eligibility for that, so that it is lawful then to import e-cigarettes containing nicotine, basically just requires that you support that with a prescription. There's no further obligation on you or the medical practitioner in relation to that particular pathway. So there are sort of, in a sense, 3 pathways, I suppose, possibly 4, but there's the Special Access Scheme B supply import pathway that John mentioned, as well as authorised prescribers and medical practitioners. But for individuals, it is open to you to use the personal importation scheme, provided that it's supported with a prescription, and there are other limitations about, months of supply.
And generally what an individual does is keep their original copy of the prescription, but send off a scan from their mobile phone or whatever, or a photocopy if they're sending a hard copy in. Often it's been with the goods, and then if customs do have any questions, the individual shows they have a prescription, or else there's already a copy of the prescription with the shipment. But while individuals under this proposed change will still be free to import directly once they have the prescription, we do think that it'll be cheaper and more convenient as more either Australian online suppliers come available or their local pharmacy, rather than having to go through the hassle of paying courier fees. Even though the purchasing on the web is easy, it hurts your credit card when you've got to pay $35 sometimes to have a box of something shipped from the US.
So following on from that, we've got a question specifically about the personal importation system or scheme, and how can a consumer or their GP be confident that the product they're purchasing is safe, and what other chemicals it might contain intentionally or inadvertently be contaminated with?
I might take that. There is that challenge with overseas sources because there are a range of companies. In general, I know there were issues with what actually was homemade or fraudulent cannabidiol containing vaping fluids in the US, and then sadly a number of people died. That was largely because it appears a contamination with vitamin E acetate and a few other things that shouldn't be vaped. But the mainstream manufacturers and suppliers of this is a problem that individuals have now, of course, in purchasing from unknown companies across the world that just happen to have a good price and a flashy website. So it is a problem, and we expect that as more local companies are involved as part of the pharmaceutical supply chain, and indeed pharmaceutical suppliers become involved, that there'll be greater oversight and confidence in the quality of the products. So those companies will want to know a bit about the analysis and the quality assurance of those products. So I think it'll be a bit like the purchasing of complementary medicines, but we should have greater confidence in Australian sourced products than in overseas sourced products. But at the moment, of course, people have the risk of not knowing about what they're purchasing from overseas, about the quality.
And other countries are themselves putting in requirements for standards, such as the UK and New Zealand. So to some extent, there could be some.
Yeah, so some countries, for example, New Zealand is planning to bring in after their election a range of quality standards for products. And so you would then, if you either individually imported a product from a New Zealand supplier, or if the Australian company wholesaled from that New Zealand supplier, those products would meet the New Zealand standard, which is it's going up for public consultation, and it's quite rigorous. So that's probably better than going to, the Wild West to get your products. And, some countries like the US tend to have less regulation around the quality and purity of their products. And as we saw, sadly, even though it wasn't nicotine, with the cannabidiol containing products, there were sadly quite a number of deaths associated with the cannabidiol vaping.
Sort of following on from that about whether there, what restrictions there might be on concentrations and strengths is another question that people are asking, and specifically, got quite a specific one. Can vapers import 10% nicotine liquid under the new regulations, should they be made, or should the interim decision be confirmed, to mix with locally purchased flavoured nicotine-free e-liquid?
At the moment, of course, the regulations haven't been made, and we're going through a process of consultation. One of the things this is the second of 3 webinars, and one of the things that was raised at the last webinar was, on one hand, that would be a convenient option for importing a small amount of concentrated product to add to legally sourced non-nicotine containing vaping liquids. On the other hand, some people at the last webinar also expressed concerns about importation of quite concentrated nicotine-containing fluids because of the safety issues, both for individuals and, again, for things like children and so forth. So whether there should be, certainly there wasn't any intent on ready-to-use, whether there should be any control on ready-to-use fluids, right up at the, say, 24 and 36 milligram per mil strength. But 10% is, of course, 100 milligrams per mil. And so it's an open question, and this is the sort of thing we want. This is a sort of deep thinking that and I know the delegate would very much appreciate receiving these sorts of considerations in the consultation, because the process for several decades has been to put out an interim decision. Sometimes quite a different final decision is made. Sometimes a finessed final decision is made looking at safety and quality and other issues. So I think that's a very good question, and I don't know where the delegate will go, but I think it will be one of the things the delegate will consider from a safety point of view. On the other hand, I can understand the arguments for convenience, that you could shandy it with non-nicotine containing local vape fluids.
We have also got some questions that are, I guess, questioning why liquid nicotine couldn't be sold in vape shops, why that's not an option being considered, and why suggesting that legalising liquid nicotine in that way would actually have reduce the black market. So,
well, we believe the black market import piece will be covered off, as I've explained, by virtue of it being a medicine, and therefore the powers that the customs people have. And of course, the local black market issue, obviously there has to be an imported source, because there's no more any nicotine produced legally in Australia. Australia doesn't grow commercial tobacco, and the economics of making vape fluids is still that it tends to come from leaf tobacco rather than chemically synthesised nicotine. On to why not vape shops. The view is that nicotine for smoking cessation and smoking cessation as a whole is probably one of the most important individual health decisions that you can make. And it needs to be looked at with the other medicines that you're on, your cardiovascular, your lung fitness, all the things that doctors do and talk about with their patients when you have a regular consultation. And so because of that, it was felt that having the smoking cessation discussion as part of a medical consultation will have much greater impact. There's also evidence out there that if a doctor is involved, and this is, forget e-cigs, this is just smoking cessation in general, there's a lot of evidence out there in the public health literature that shows that if a doctor is involved in the discussion about smoking cessation, while most cases, sadly, of smoking cessation fail, your chance of success is much greater if your doctor's involved.
I've got a question here from a consumer who currently has a script, is using the personal importation scheme, and has a script, and is asking, how is what's proposed different to what I'm currently doing?
It's not different at all for you, because you've got a script for smoking cessation. The main difference is that the vast majority of e-cigarette nicotine is coming in for non-medical use or not associated with a smoking cessation discussion, even though many people say that they're doing it for smoking cessation. And by requiring the involvement of a medical doctor, we believe that will actually strengthen the ability of e-cigarettes and or other strategies to contribute to smoking cessation. But for you, the person who's asked that question, nothing will change. The only thing is that I expect it will be even easier to access quality sources. Whether it's cheaper or not, on one hand, pharmacies, I believe that it is, and I can only base it on what we see from other medicines imports. As I've mentioned, there's 110,000 under the Special Access Scheme every year. And we know that the costs of bringing in individual parcels by courier does almost often cost more than the actual medicine in that box. And therefore, once there's a critical mass of local suppliers, we genuinely do believe the cost will be lower, but that will be up to the market to work out. But for you, there won't be a change. If anything, it'll become easier to access a wider range of products locally.
So on that, a follow-up to that, would they be likely to have their script checked more frequently by Border Force?
They will be, and so what we suggest people do is to send off an image of their script, or to just make sure they retain the individual script.
Okay. I think we've covered a lot of ground here, so I'm trying to find some unique questions that are coming in. I think we've had some more questions about the spray and the inhalator, and that might be something that we need to clarify on the Q&A following this, because there possibly is a little bit of misunderstanding.
The main difference is that those sprays have been thoroughly evaluated by TGA as registered medicines. They've provided information on their quality, their safety. They've also provided information on how quickly the nicotine from them enters the body and what the maximum levels are. And in general, the levels and the speed at which even from a spray, the nicotine comes into the body is slower than vaping, especially from a high-strength vaping fluid or from a nicotine salt.
And the delivery area is different.
Well, the delivery changes. I mean, some of the inhalation things do go down to the top of the lungs. It's still different. It's still a different inhalation process from vaping when it's a pressurised spray, and certainly the lozenges and the patches, the delivery is different. So a patch is absorbed through your skin very slowly over a long period of time. That's good as far as not poisoning yourself with nicotine, but it's often not seen as a very good mimic for smoking cessation. And I use the analogy, it's a little bit like trying to give up vodka binging by drinking light beer. It basically won't work for a lot of people because the amount of nicotine and the speed at which it enters the body from some of those patches is a bit slow.
And John, I noticed even some of the comments on the mist, the intent of the mist is to actually be absorbed through the mouth, not actually through the lungs as well.
Yeah, a lot of it varies, and certainly a vaping product goes right down into the lungs, down to the bottom of the lungs even at times, whereas those mists, only some of it gets down there, and a lot of it stays up and is absorbed through the cheek, the buccal layers of the cheek and so forth. So they do vary.
We have a question about how the interim decision impacts heat-not-burn products.
Well, essentially, it does and it doesn't. So it's actually, the simplest message is it doesn't change the status quo, I think it's fair to say, of heat-not-burn in the broad sense, but they
would be clarified to be on prescription.
Yeah, it changes it in one stretch, but it would be possible to get a heat-not-burn cigarette on prescription. It would change that status, but it wouldn't. As people may be aware, there was a proposal from a large tobacco company, and I can say that because Philip Morris made it public, to turn heat-not-burn into the same as combustible tobacco. But the issue of law is that carve-out, along with the printer's inks and the photographic chemicals, is only for smoking tobacco that actually you burn. So heat-not-burn was not able to be put under that same carve-out, but it would be able to be prescribed in the same way as vaping. Now, I've never heard of a prescription for heat-not-burn, but it is legally possible. Yes.
We have a few questions here around prescribing and questions around what does a GP have to do to be able to officially prescribe it, and what does a prescription look like? Okay, very little. So in both cases. So all the GP would have to do to become an authorised prescriber, and of course it's not up there yet because we're still at an interim decision stage and we've got to work out whether the delegate makes a final decision. But subject to a final decision being made, a GP prescriber, the simplest way is to just put your name, address and APRA number into a pre-filled form. That means that for 5 years, and it's free, 5 years you have an authorisation for writing scripts for vaping for smoking cessation. It doesn't specify particular quantities or concentrations. Those amounts can be put on the script, and there is some information on our website on possible strengths and so forth, and there'll be more and more of that information if the final decision's made. So the actual process for a prescriber is very, very simple. They use a standard prescription form, but it goes under the authorised prescriber scheme because it's an unapproved therapeutic good.
And I think the important thing to understand with the process too is, while we anticipate a decision to be made mid-December, at the time that decision is announced, the delegate will also announce an implementation date. So none of these changes actually come into effect until that implementation date. So depending on what the announcement is, we will have time in which to resolve a lot of these issues, answer questions and provide education and support material before the actual implementation date for any decision.
Yeah. So I think the questions are starting to slow down in terms of we've covered quite a lot of ground.
I'm happy to answer. Was there a question about benchmarks for success that's just come in?
Oh, maybe. It hasn't reached me yet, but I'll have a quick read.
So I think one of the questions that came in that I saw out of the corner of my eye was, what would be the benchmarks for success from a public health point of view? And I can only give you a personal view on that, but I wouldn't be surprised that aligned with a number of public health physicians. I think the first benchmark for success would be a reduction in the number of young Australians who have taken up vaping of nicotine-containing vapes. Now, while those numbers are still significantly smaller than North America, they're not zero, and so a reduction in the number, because we have seen a doubling in the last couple of years. It'd be great to see a halving. So reduction of the number of young people who are taking on nicotine. The broader thing would be, over a longer period of time, is a reduction in the stubborn last 10, 12, depending on how you cut your numbers, 10, 11, 12% of Australians who smoke. Australia's made tremendous strides from the 70s, for example, when I think the number, and again, someone on this line will know better than I, when I think it was about 35 or 40%, and we've got down into the low numbers of 11, 12, 13%. So if in 5 years' time we could be down at 8%, and and the evidence is starting to look more promising for e-cigs helping in smoking cessation, although the trials haven't been big enough in many cases, and they haven't been long enough. So many of the trials, and I guess their research funding ran out, was people didn't smoke for 8 or 12 weeks. Well, as many of you will know, that's not permanent smoking cessation, 8 or 12 weeks. So I think the benchmarks of fewer adults smoking and certainly fewer kids taking up vaping or smoking would be wonderful benchmarks to have, and there'd be fantastic impacts for the health of the nation.
Thanks. Well spotted, that question, just as it came in. What we're doing at the moment is running a bit of a poll. Now, I just want to clarify, this poll is not about whether or not you agree with the interim decision. Please give your feedback on the interim decision through the submission process. This is a poll about the delivery of the webinar today and whether it was useful for you. So I'm grateful if you could complete it, and then it also gives you an opportunity to send in any last few questions that we may not have covered. But in any case, if we haven't answered your question, we will be going back and looking at all of the questions and putting something up on our website that hopefully covers those. So we've got, while we're doing that poll, a couple of a few last questions.
We'll take, what, 2 or 3 more? And
yeah.
my colleagues can
We've had a couple of questions about recreational use that have come in throughout, comparing nicotine to, for instance, caffeine. And, why can't I continue to use nicotine recreationally just as I would caffeine?
That is a scientific question.
Well, okay, I'll take it as a scientist. Essentially, nicotine's much more deadly. There are controls on caffeine. So some of you may remember a young chap, 21-year-old by the name of Lachlan Foot, I think his name was. Sorry to his parents if I get his surname wrong. Who died from having too much caffeine in a sports supplement in a shake. I think it was New Year's Day a year or 2 ago in the Blue Mountains. And there have been a number of deaths from too much caffeine globally, and there's certainly been a large number of people having heart attacks, myocardial infarcts, arrhythmias from too much caffeine. So believe it or not, there actually are limitations on caffeine, both in foods and drinks. Those energy drinks might have a lot of caffeine in them, but there's a legal limit. And similarly in medicines, even in the pills that truck drivers might use for keeping awake driving up and down the Hume Highway, there are still limits on the amount of caffeine. So again, and that's through the same process of scheduling. So caffeine is not harmless, but nicotine, all the toxicity or the medical data shows that nicotine is much more toxic than caffeine. So continue to have your 1, 2 or 3 cups of coffee, but if you started to have 15 espresso coffees a day, you'd also be very sick.
So we've got a follow-up question to that, which is just about having limits on nicotine dosage, I guess, is perhaps that person has taken that forward.
Well, again, that's something the delegate will have to consider. We had the question earlier, for example, whether a 10% nicotine fluid, even if it's intended to shandy, would be okay because of the risk of maybe someone vaping it directly, but get a rude shock. These are things that the delegate will want to see in the submissions, and that's why this extra month, which is written down in law, is so important in coming to the best possible decision.
One final question, I think, and it's actually around supporting people with mental health problems and whether there'll be specific supports in place for them.
Yes, we met with I mentioned that we'd talked to a number of groups. Some time ago, we'd met with the College of Psychiatrists, who of course are the professional group of doctors who deal with people particularly with the more serious mental health issues. And they are well aware that whereas, and again, the figure, depending on which community you look at, is in the early teens, but when you go to various groups of people, be it people with bipolar disorder or people with depression or people with other mental illnesses, the figures vary. You can be up at 50% of smokers even, and certainly more than 35% depending on your classification of mental illness. And so the College of Psychiatrists is actually quite supportive of transitioning people from smoking at least to e-cigarettes and then potentially again with a view to cessation. So they're an important group of doctors, and again, if this does become a final decision, it's a group that we'll engage carefully with, and I think it will be important to develop special materials without stigmatising people, to develop special materials for those who may have mental illnesses but are interested in giving up smoking combustible cigarettes.
Okay. I think we might leave it there then.
Yeah. Well, thanks everyone. It's been a very interesting hour and a half. You can continue to submit questions. You've got the email address that was given earlier, and we will be putting this presentation up on the web on tga.gov.au. We certainly encourage submissions. We're certain we'll get a spectrum of submissions from those who are concerned that on one hand it could be seen as restricting access to e-cigarettes. On the others, we'll have some groups who might believe that this is liberalising access of e-cigarettes too much. That's the life of a regulator. You get a broad range of views, but hopefully it will help arrive at the best decision, and also a decision about, if it was made, about the implementation period. So thanks so much for the almost 100 of you online today. We do have a final session tomorrow for those who couldn't make today's webinar. It'll be a repeat of this one, but it'll also be an opportunity to have the discussion more broadly. And thanks again for your time, and stay safe. Good evening.